So thank you for this very kind introduction. So my name is Eibinger. I'm a trauma surgeon here at the University Hospital in Graz and also working as emergency physician on the response car in the pre-hospital setting. So I was invited to talk about some clinical cases and about some clinical background of the eFAST protocol and why we need it and why we use it. Yes. So why do we need the eFAST protocol? If you take a look at this slide, you see if we compare the time from the eFAST to the CT scan, we lose around 15 minutes from the start of the examination, and you don't have to forget that the CT scan at least needs another 10 minutes. So we are going to lose probably 25 minutes from the diagnosis. So every patient who enters the trauma bay with the helicopter or with the emergency response car usually gets an eFAST examination first in the resuscitation area. Because if we find something like free fluid in the abdomen, the patient is going immediately to the OR, usually if the patient is hemodynamically unstable. So before we talk about the eFAST, you need to know which things you can see in the eFAST and which things you cannot see in the eFAST protocol. So what's pro eFAST? First thing, it's a very fast examination. If you are skilled in doing your eFAST, you usually don't need longer than 1 or 2 minutes to perform the examination. It's a simple examination and it's very well trainable. You can make a direct surgical decision after you have performed the examination. In times like these, it's also a very economic examination because you only need to buy one ultrasound and then you can do the examination 1,000 times or more. You only need less human resources because only one person is needed to do the examination. And it's repeatable. So if you aren't sure with the examination first, you can do it a few minutes later again, and it's no harm for the patient. And you have no radiation. But what are the eFAST gaps? So what I can't examine with this tool? First thing is I can't see the retroperitoneum, so I'm not able to recognize an injury of the kidney or the pelvis vessels or other things that are in the retroperitoneum. Another thing is I can't do an exam of the mediastinal cavity. So I can take a look on the heart, but not on the big vessels that are in the mediastinum. I can't see subcapsular hematomas. It's very difficult to perform the examination fast if the patient is very obese, so that's a limitation. If the patient has, for example, a pneumothorax and have a skin emphysema, I can't also use the eFAST because through the air that's in the soft tissues, I'm not able to see anything. And why we do the eFAST? Before I come to the cases, there are some studies summarized for you. So this was a very big prospective study that was published a few years ago. They included 430 patients. As I said, this was prospective. They make as where stable and unstable patients were included, and one good thing was all pneumothoraces that requiring a chest tube were identified in this study. And they say it's very sensible and cost and radiation saving if you compare it to a CT scan, for example. Another study that was only focused on the pneumothorax, they included 109 patients, only blunt trauma patients. They matched eFAST versus CT scan, And here you see, if you compare it with the CT, you have a gap. Yeah? So only 63 of 106 pneumothoraxes were detected in the ultrasound, which is a sensitivity of 95%. But if you compare it with the pneumothorax that needed a chest tube, they found 81%. And the eFAST is very, very good in ventral pneumothoraxes, but you have a problem with pneumothorax that are in the apical area of the lung or in the basal area. There was another story which, as a study which only take a look at the free fluid in FAST in comparison to CT scan, and they make a comparison between emergency physicians and radiologists. Yeah? So the emergency physicians found more than 90% of the free fluid in the abdomen. The radiologists found a little bit more, but you see it's not a big difference. So usually, if you don't have the luxus that there is a radiologist available in the trauma bay, for example, it's not a problem if an emergency physician or a trained surgeon is performing this protocol. And then we take a look at the pre-hospital eFAST. So I can say here in Styria, we use it. We have an ultrasound, a mobile ultrasound on each emergency response car and on every helicopter. And we are doing the eFAST on scene directly. And sometimes it's changed the way how we treat the patient. If we, for example, find the pneumothorax, we usually do chest drain on scene. And if we have free fluid in the abdomen, it changed the management of the patient as well. And there was a moderate evidence that the pre-hospital ultrasound is good if physicians can perform it, and there's a change in the treatment in trauma patients, and there was no benefit for paramedics if they use the ultrasound on scene. So that's some theory we can talk, and now we are going to the very important things for you, the cases. So case one is a 20-year-old male patient. It was a motorcyclist. The trauma mechanism is very interesting because he tried to perform a wheelie on the motorway with around 130 kilometers an hour. So it's not the best decision, I think. Yeah. The patient was transported via helicopter to our trauma bay. He was intubated, and the announcement was this was a severe polytraumatized patient. This is our polytrauma protocol, which we use in the trauma bay. So you see here here you have the initial blood pressure was around 80 to 40 in the trauma bay with a heart rate from 120. So you can see that the patient is not in quite a good condition. You here also see that the patient was getting a lot of medications that we keep in somehow stable. So this is yet now the first ultrasound image from this case. We have the look at the liver here, and here you have the spleen, and you see here around the liver corner you have some free fluid. If we take a look at the spleen, yeah, you also have here some free fluid. This is the CT scan we performed afterwards, and here you also see downwards the liver, this area. So this is the hematoma which you see in the ultrasound, the free fluid. And also around here, the spleen, you also have here some free fluid. That's the same patient with the bladder. Here you have the bladder, and here you have also some free fluid there. So what was happened to the patient? The patient was undergoing immediately surgery afterwards, so it was performed the liver segment resection and the splenectomy. Let's go to the next case. 19-year-old male patient, car accident, crashes into tree, was transported by ambulance car to our trauma bay. We have the announcement was a blunt thoracic trauma and abdominal trauma. Also here you have the the protocol from the trauma bay. Here you also see that the patient is in a very critical condition, only with 62 blood pressure, heart rate of 120. So also this patient is very unstable. This you have the first ultrasound image here. You also have here massive free fluid around the liver. If you continue here to the spleen area, you also have here the free fluid left. And this is a very impressive image from the bladder area. Usually you don't see that much fluid in the small pelvis down there, but here you have around the bladder massive free fluid. This was a CT scan performed after surgery. Here you have the disruption, the complete disruption of the liver. This white thing inside here are some gauze because the patient underwent an hepatic packing. So we put some gauze around the liver and compress it, and then you close the abdomen. So what was done, first the liver packing, and after 2 hours later, there was a segmental resection performed because the patient was getting in stable conditions. The next thing, now we have 19-year male patient. He was stabbed by his classmates. So that's a problem we see more and more often. So stab wounds are getting a bigger problem now, even in Austria. Patient was transported with helicopter. The announcement was penetrating thoracic trauma. If you take a look at these values, so we have a blood pressure 113 to 68, heart rate 81, and the respiratory rate was around 15. So the patient isn't in so bad condition. So that was the first image from the heart. Does anybody see anything? No. So we have a normal heart here, no fluid around, so no pericardial tamponade. Yeah. So also here we have the spleen that looks completely normal. Also around the bladder, there's no fluid here. But as I mentioned, the patient has a stab wound in the thorax. So if we go to this image now, here you see a different, this was the right side, and this the left side, yeah? If you take here a look at the motion mod from the ultrasound, you see here the so-called barcode sign, which is a sign for a pneumothorax because you have no movement of the pleura. And here you have the healthy side. It's called this so-called seashore sign. So here you have no movement because that's the chest wall. And this is the movement of the pleura when the patient breathes, yeah? So this, you can use the motion mod if you're unsure if you have a pneumothorax or not. Usually every ultrasound has the possibility to activate this motion mod. This is the CT scan of the thorax afterwards. Here you have the lung. You have here, the black thing here is now the air, and you also have a lot of air here in the subcutaneous tissues. Yeah? The problem is if the air in the subcutaneous tissues goes up to the column, it's a little bit more dangerous. So what happened to this patient? He got a thoracoscopic exploration and afterwards a chest drainage. The next case is a very recent case from our department, a 20-year-old female, also again a motorcyclist, transported with helicopter, again intubated, chest tube on both sides, severe polytrauma was the announcement. Patient was very, very unstable in the pre-hospital setting with a blood pressure from around 60 to 30. When the patient arrived in the trauma bay, the first thing that happened was the eFAST, and afterwards we entered a rebore catheter. So we blocked the aorta. This is the image from the liver, and you see, even it's only a eFAST where you usually only should take a look if there's free fluid or not. You have here a massive disruption of the liver. So here we have liver, here we have liver, and there's a big hole with blood. Yeah, so the liver was completely torn. Around the spleen, you have also free fluid here. And also in this case, you have massively free fluid in around the small pelvis. Patient was, after rebore, the patient was immediately put to the OR, and there was a laparotomy performed. There was a hole in the vena cava inferior, and the liver was completely disrupted. Yeah, so I'm finished with my talk. If there are any questions, feel free.
So thank you very much. I think we already have a question.
I can just say it loud.
Okay, maybe for the audience in the live stream, you'll get a microphone as well.
I'm sorry, I'm from Czech Republic. In Czech Republic, we don't have an ultrasound in every ambulance, but I was wondering, so if the ambulance gets there first, the paramedics are doing the eFAST?
No, so in Austria, the paramedics don't have an eFAST. It's only on the emergency response cars where the emergency physician is on the car or on the helicopter. So the normal ambulance don't have the ultrasound.
Okay, so that was for my clarification. Thank you very much. And another question. If you use a vacuum mattress for some polytraumas, you do the eFAST before, because after it, you can't really reach out to the left and right sections and check it, and you do just directly CT and check the abdomen a little bit, or how is your approach different in this situation?
Usually on scene, it's no problem because we do the eFAST usually before the patient is put in the vacuum mattress. Yeah. In our resuscitation area, usually we remove the vacuum mattress and the patient is going on another table, and we do the CT scan also without the vacuum mattress. So patient enters, we put in on our table, we make the eFAST exam, and then we decide what to do next, if we need to go CT or RR. Yeah.
Okay, thank you very much.
Yeah, similar situation in different countries. So what would be your approach if we know that our ambulances and like also helicopters aren't suitable to perform like eFAST there? So would we go with the patient straight for the CT or perform it first when the patient gets to the hospital?
So we usually, even if we do an eFAST on scene, the eFAST is going to be repeated in the hospital, because the situation can change, and we don't put the patient directly in the CT usually, in our trauma bay, So we always repeat the eFAST, because if there's a change, in the eFAST that is going on scene or in the hospital, probably you don't have the time to do the CT,
And personal curiosity, what about the motorcyclist patient, the last one? Did she survive?
No, patient died.
Oh, okay. Thank you.
Are there any other questions from the audience? Okay, perfect.
I was wondering, if you find free fluid, do you go straight to the OR, or does it depend on how much fluid you find? And if you do go to the OR, do you just go straight to a laparotomy, or?
Yeah, so usually it's depending on the stability of the patient. So if we have free fluid in the abdomen and the patient is in a stable condition, we perform CT scan, because we don't have to act immediately. If the patient is unstable, then we usually go straight to the OR and perform laparotomy. So.